places not in London and further out of the city who are behind the curve, who essentially, because people don't, go into intensive care and come out the next day, they certainly weren't doing at this point, that has implications for kind of whether the remaining capacity in the regions, for want of a better word, and I'm quite sensitive about this because I live in the regions, I don't live in London, what that does to the remaining capacity. So exceed NHS capacity is possibly a slightly loose term because you can kind of sleep out by region, but it still has implications for the totality of the NHS bed capability.
The material around this time uses, as you've already identified, a number of different ways of describing the impact on the NHS. Overwhelming, overtopping,
Yep.
Exceeding capacity, straining the surge capacity, and so on and so forth. Is this the position, as you understood it at that SAGE meeting? There was no hard data saying there is a stop point, a hard date by which the NHS will be broken, but that instead, if the epidemiological trajectory or curve continues in the way that it has, it will inevitably be broken at some indeterminate point in the future. Is that the nub of it?
Yeah, so hard stops are really kind of bad expression for the reasons I've given, that, if you're short of capacity in one area, you kind of move out and ship out and sleep out into the other areas. But the NHS is nevertheless finite in the number of staff and the number of beds. And so I think that's right. I think that's the
correct
yes.
analysis.
You did say something else, and I've forgotten it.
No, I think that was all I said.
Okay.
And secondly, obviously on that 23rd of March, only a few days had passed since the measures had been imposed the previous week.
Yes.
On the 16th and then the 20th. The household isolation, the individual isolation, then the household isolation, then the request that all non-essential businesses and travel stop, and that people endeavour to stay at home. What was your understanding of what the likely impact of those measures was in terms of the R figure? Because as Sir Christopher has explained it, it's not that government was grappling with absolute data as to when or how the NHS would collapse. It is just that if the the reproduction figure was not brought below 1, the exponential growth would continue, and that point would inevitably be reached. What debate was there about giving more time for the measures the week before, time to bed in, and for the R figure to come down, in the expectation or hope that it would come down before that future date of collapse of the NHS would be reached?
Well, if you enact measures on, say, the 20th of the month, then you if everybody complies with the measures on that date, you change exposures from that date. You therefore change case incidence, shall we say, 5 to 7 days later, something like that. So you don't see the impact of that. You then don't see the impact of those new cases for another 7 days until they require hospital care. So that kind of takes us into quite a way into the next month. And by the exhibit you've just put up, the doubling time for intensive care unit patients at this point was estimated to be 3 to 4 days. So how can you wait to see the results of those measures when you're in such a kind of difficult position in terms of bed number doubling?
There was nevertheless some way of assessing compliance or the reaction to or the response to those earlier existing measures, because there was some information at the weekend about levels of compliance, and you recall the fact that the press and the television showed large numbers of people attending national parks over that weekend. So there was data about that. Is therefore the position that the quandary the government was in this? Nobody could say for sure what the impact had been or would be of the existing measures. No one could know for sure because, as you say, it would take days, if not weeks, for the impact to become clear. What, therefore, the impact would be, and that was an unconscionable risk to run. If you don't know what the beneficial impact had been of the week before, you cannot continue on the basis that you've just got to hope it will work, given the characteristics of the viral pandemic.
So I understand the question entirely. What I don't think I can do is give you the kind of technical answer you require, which I think the modellers would need to give you about what their views were about the likelihood of those phase one measures, if that's the right word, having the desired impact. I wasn't close enough to it at that point.
I don't wish you to speak on behalf of the modellers.
No, and I can't really give you an answer then.
But was this not a debate that was taking place within SAGE on that day? How do we weigh up the prospect that the phase one measures are going to work to get us out of the hole against the risk that if we don't act now with further more stringent measures, it'll be too late? That's the crisis. That's the dichotomy.
Yeah, I've pledged to be truthful, and I will, and I can't remember.
All right. Can I now raise just some other separate, disparate areas? The Coronavirus Action Plan of the 3rd of March.
Yes.
Did you ever hand, Professor, in its drafting or its promulgation?
I undoubtedly received a copy of it to make some kind of track changes and suggestions to. In fact, I think if you were able to kind of look at the email records, you'd probably see that that was the case. It was another job to do. I was rather more focused on specific jobs I had to do connected with fighting the virus than writing a glossy pamphlet about how I was going to play my role in it, or how the government was going to do it. So I'll be perfectly truthful with you. It was another job that probably wasn't very welcome at the time, and I just thought, well, see it through.
May I ask
Let others do it.
May I ask you this? You've told us how you'd already reached the view in mid-February that
Yep.
there was sustained community transmission, essentially containment had been lost. You must have wondered around about the 2nd of March when you were contributing to the final draft, why am I assisting in the drafting of a document which is based on the premise that containment has not yet been lost, and indeed the government didn't announce it was lost until the 12th of March.
The drafting of government documents takes forever and a day, and it wasn't really something that I was focused on or really had the kind of mental and professional energy to worry about.
All right.
I've written down I was focusing on actions not planned, not words.
Yes, I was, I'm afraid. Yes.
Well, that perhaps is a very useful description of certain publications. Milady, is that a convenient point?
It is, certainly. We take a 15-minute break, Professor, so I shall return at 3:25. All rise. But we shall complete your evidence today, I promise.
Professor, mass gatherings.
Yes.
I detect a quiet groan. It was an issue upon which you advised the Secretary of State for the Department for Culture, Media and Sport in late February. And you also provided advice to DHSE colleagues at the same time. You met with officials in the DCMS in early March. You provided further advice and further papers for a number of government departments in the middle of March, 14th of March. So you were to a considerable extent the go-to person on this issue. In summary, scientifically, epidemiologically, was there a consistent line of advice given by the OCMO to the effect that banning mass gatherings or closing sporting events or sporting occasions would be unlikely to make much of a difference epidemiologically.
Yes, I mean, our position, my position, has always been that mass gatherings, particularly outdoor ones, are if you cancel them, they're a very limited epidemiological effect. And if you take into account the kind of pathways around them, it is the activities around them that is, potentially more concerning in relation to kind of pubs, bars, restaurants, etc. But even so, in relation, for example, to, I know you've already discussed a couple of big sporting events in different countries with various witnesses. In terms of the kind of totality of movement between countries, the effect of kind of cancellation of these events is really epidemiologically quite small. I have also heard Sir Chris's comments, and I have to say I think he's got a very valid point that there is a political layer above this around the optics and what the continuation of mass gatherings means, signifies to the public, because when the football's over, there's not much left to do in life, as it were. So from that perspective,
Well, I have to interrupt you there, Professor. That is your personal view.
Yes, indeed. Yes, but the point is, it's very symbolic for a lot of people what these mass gatherings are. And I think Chris summarised it very well. I don't think I can add to that.
Can I just ask you one extra question for that? I think it's something Mr. Weatherby was asking about earlier. And that is, but what if your football match involves a whole bunch, thousands of people flying in from another country where there is a hotspot of infection? Or hotspots of infection?
So that partly depends on whether there are lots of other people coming in through kind of routine tourism and so forth from that other country. And it really depends upon whether you have a belief that the virus is already seeded here in the UK, and whether that additional movement would really be an amplification in relation to what is already going on under the surface in your own country, particularly in those kind of early months when we know we couldn't test at the capacity required to understand the UK case burden.
I'm no scientist, but aren't you just raising the risk? It's not going to help matters?
I think it's perfectly fair to say that it won't help matters, but equally, it isn't going to it just isn't going to have a significant negative impact either in relation to the totality of what else is going on. So it's back to this point that I think it's always very difficult in this space to separate out the optics from the actual epidemiological effects. But I can recall emails from other experts. I think Professor Ferguson, Professor Edmonds, also agreeing that the effect of mass gatherings is
Professor
very slight.
Ferguson, in fact, was asked to advise specifically on this point, and we've seen the evidence.
Yeah.
But just to conclude this subject, Professor, when you say political and you refer to the optics, do you mean, in fact, that in terms of the public health message that went out, the continuation of mass sporting events was, with hindsight, ill-advised? It just sent the wrong message.
It was unhelpful.
You can't talk about closing primary schools and allow sporting events to continue, can you?
It was unhelpful.
All right. And then, secondly, just on the epidemiological side, that there's some suggestion in the material that whilst it's clear that outdoor sporting events epidemiologically are insignificant because they're outdoor, there may have been an underestimate of the epidemiological consequences of queuing to get into games, or perhaps using public transport or the use of trains. And as my lady has observed, that's one way perhaps in which people may be coming together to go to a game, and therefore there was an epidemiological risk there, which perhaps wasn't fully appreciated at the time this advice was given.
Whenever you get people gathering together in conditions of close contact, low ventilation, with this virus, you're likely to get transmission. The however many tens of thousands one could get into a stadium will be dwarfed by the however many millions that are gathering in pubs to watch it on Sky TV. So, there's a broader context here of what the sporting event generates in terms of people coming together, quite often to drink alcohol, which we know reduces social barriers, to observe a sporting event.
Indeed. The easing of restrictions.
Yes.
On the 26th of May, you contributed to a joint letter to Simon Case, the then Permanent Secretary in number 10. Could we have 69418?
Yes.
In essence, in general terms, you and your colleagues were writing to the government to say this. You're aware that different government departments are eager to restart their industries. You're obviously acutely aware of the damage and harm that is being done to the health and welfare of societies by virtue of the restrictions. But you nevertheless felt it important enough to warn that the combined effect of seemingly incremental and narrow easings raised essentially an intolerable risk that our reproduction number would run out of control again. Why was it necessary to write this letter as opposed to just continue to contribute to the sum of government learning by the advices that you were giving with your colleagues day in, day out at meetings, by email and so on and so forth?
Yeah, okay. So the actual restriction, the easing of restrictions that was happening on a piecemeal basis, government by government, department, kind of setting by setting by setting, and it was relatively easy to justify for an individual setting that this was kind of okay to ease restrictions. There when you put all of those together, there was a risk. Your words were intolerable, they're not mine, but there was a risk that this would all go too fast.
Well, you say severe risk, if I may observe, of a second.
Intolerable's not a word I don't think I use.
All right. Well, a fair point.
But there was a risk that this would all go too fast. And there was a risk that we knew there would be further waves of infection. Epidemiologists knew that at some point. There was a risk that if you kind of let it go, let it kind of rebuild and get a lot of momentum, you would then enter the next wave from a fairly high level and therefore have less warning and therefore with more consequences. So that was the kind of science reasoning behind the letter. Why the letter rather than just continuing to cooperate? And I think that was about, certainly for me, and I can only speak for my signature on the letter, I wanted to leave a mark in the sand here.
Why was it necessary to leave a mark in the sand if you were, as you were, of course, the DCMO, giving advice on a daily basis to government with your colleagues?
Because people like you have come back to it now, and it's kind of on record that I was concerned enough to write a formal letter to CABSEC at this point because of those concerns that I've already relayed to you in the room.
But they were concerns that you would have been ordinarily expressing in the course of your day-to-day meetings, because all of you were exclusively concerned, of course, with the pandemic and with the easing of restrictions and the debate that was going on.
But sometimes a letter is needed.
Why was it needed?
As I said, to lay down a trail in writing that was incontrovertible, that we wanted to say that this needed to be taken very carefully.
If
that suggests you didn't think your oral advice was being taken sufficiently seriously.
I think it could partly suggest that, but it could also partly reflect the kind of fragmentation of decisions across different sectors, and therefore possibly the CABSEC, not being an epidemiologist that I'm aware of, not being able to crystallise the net result of those individual sector liftings and frame that in terms of the national epidemiology. So, I don't think it was because we kind of felt we'd run out of road in terms of, getting traction with officials from other government departments, not at all. But I just think it was more about the totality and somebody who's responsible for the totality actually being presented with that concern.
Professor, it is common ground, it's well established, that as these things go, the level of prevalence remained relatively high, or at least not very low, throughout the course of the summer months. We came out of the restrictions with the prevalence still at a relatively significant level, and that didn't change. Then in September, there was a debate, which we're not going to go into, about the necessity for circuit breakers, then the introduction, or instead of a tier system in October, and then ultimately the lockdown in the beginning of November.
Yeah.
In general terms, do you assess that this warning, which is what it surely was, because the last paragraph shows what might happen if control is lost, was generally heeded?
I suppose the epidemiology really just speaks for itself at this point.
But could you tell us, please?
Yeah. It was clear that we were losing control of the virus bit by bit through the autumn again. And it was clear that the tier system, to my mind, was not working efficiently. That isn't to say that theoretically it couldn't have worked efficiently, but there were just too many delays in implementing tiered restrictions. Those on top of the fact that your data you're dealing with, again, and I go back to the point, reflect exposures 2 weeks before, or at least a week before. So, you're already kind of, dealing with yesterday's data, trying to make decisions. So, and the tier system just seemed interminably slow between a decision and the negotiation on the economic packages to enable it to happen. And
can we just focus on that for a moment? And could you just further explain that observation? The evidence is that in the October tier system, not the December one, but in the October one, there was a process by which local authorities who were subject to higher levels of tiering could negotiate financial packages.
I believe so, yes.
Was your concern that there was a delay built into the system between the moment at which the joint biosecurity, the joint biocentre would advise that a particular area had to go epidemiologically into a higher tier, to the point at which it was actually ordered, because there had to be a process of negotiation in the middle?
Yes.
All right. And then because of your point about the importance of not falling behind the curve and not knowing what the data in fact shows, because the data is a bit old, that gave rise to a very real problem.
Yeah, and the tier system led to some other problems too. For example, Liverpool did really well at one point and managed to kind of significantly to kind of turn their numbers down. Manchester got into more difficulty, but there were widespread reports of people from Manchester going to nightclubs in Liverpool to circumnavigate the kind of geographical boundary of the tiers. So at a practical level, I think it was very difficult to kind of make it work, and it probably looked better than it really was, which is why I just don't think the tier system served us very well at all.
You focused on the events in October, Professor. My question, in fact, was designed to elicit from you an answer as to the general governmental response from the time at which you sent the letter in May. Was the reality that the warning was not heeded to this extent? Control of the disease was lost. The steps taken by government in September, by way of the decision not to impose a circuit breaker, the decision in October to have the tier system that you've described, failed to do that very, failed to perform the very aim, the strategy which you had identified as being necessary to ensure that there wasn't a new loss of control and a new second wave.
Yes, that's correct.
All right, thank you. Eat out to help out.
Yes.
Did you, Professor, were you consulted on that scheme? We've asked the same question as Sir Patrick Vallance and Sir Chris Whitty. Were you involved in that?
Absolutely not. The first I heard about it was, I think, on the TV.
I think that indicates what view you would have taken had you been consulted.
Say again?
What view would you have taken had you been consulted?
So, had I been consulted, I wouldn't have made any distinction between Eat Out to Help Out and any other epidemiological event that brought different households into close contact with each other for the purposes of socialising, eating and consuming alcohol. The net epidemiological effect, is kind of agnostic to what's on the menu, as it were. But I would have said this is exactly encouraging what we've been trying to suppress and get on top of in the last few months. So it didn't feel sensible to me.
All right. Finally, two last subjects. Moonshot.
Yes.
You were on the Moonshot Scientific Advisory Group.
Yes.
The first meeting of which took place on the 25th of August. We've heard very little about the moonshot. What was, briefly, the moonshot idea or exercise?
So I'll give you my best understanding of it, which may not be perfect. The understanding of moonshot was to try and restore the UK to a point where we had almost no COVID. And to do that, to detect every single case there was kind of cooking or ongoing in the UK at the same time.
A mass test.
So mass population testing in a very short window of time. Now, I never got to the point where I understood whether this could be done in one day or done in 3 days, but even 3 days would be, 20 million people a day. And so I never really kind of understood that concept. But it didn't make any epidemiological sense to me because let us say that your testing day was Monday. Yeah.
For a whole swathe of the population.
For a whole
region.
Of people, yeah. And there would be a number of people who were exposed to the virus on the Sunday who absolutely would test negative on the Monday because they were incubating the organism, who would get a kind of clear result, as it were, by Tuesday or Wednesday, but who, by Thursday, may well have symptoms. So actually, you would have to repeat this over several days and keep people in isolation from each other to avoid further exposure to kind of get to the point where everyone was clear. And I just couldn't see it working. I was sent to the Moonshot meeting. I can't remember who sent me, but I was told to go on to the Moonshot meeting. And I went along. I tried to offer some, non-negative, constructive comments, but I couldn't see it working ever.
That's the epidemiological answer. Practically, as at that time in August, do you recall whether or not the United Kingdom in fact had a fully scaled up system of PCR, antigen or free flow tests that would have allowed these sorts of numbers to be tested simultaneously?
I mean that's a memory test and I can't remember the figures, but my kind of gut feel is no. And of course, there were other far more important testing environments, such as hospitals and care homes.
Indeed. Finally, communications. In your statement, you refer to the fact that there was a Japanese poster called the 3 Cs: close spaces, crowded places, and close contact setting, the merits of which commended themselves to you, and you sent a copy of that poster to the Cabinet Office in mid-June, so not during the lockdown and not save the NHS time, but afterwards. No. Why did you send a copy of that poster to the Cabinet Office in mid-June?
Well, I can't remember when I first discovered the existence of the Japanese 3 Cs concept, but it immediately resonated with me. And, you know, all I can say is it resonated with me personally, because I felt it would be a way, if we did it right, by which we could coach the public to look at any situation and just, you know, remember 3 Cs. It's pretty simple. Literally, is it closed? Corollary, and what's the ventilation like? Is it crowded? Are you putting a lot of people into that closed space? And is the purpose of them being there to have close contact with each other? And I felt that you could teach people to self-regulate almost and risk manage their own behaviours, their own exposures, if we could kind of make that concept work in the UK. And
had it been very successful in Japan?
I can't give you the answer to that. All I can say is, repeat what you said to me, that it absolutely resonated with me.
All right. You sent it to the Cabinet Office. You were told that it would be considered, this type of messaging it would be explored as to how it could be integrated into the campaign. Did you hear any more?
No.
You were the DCMO for health protection in the face of this pandemic?
Yeah.
All right. Thank you very much.
Mr. Weatherby.
Professor, I ask questions on behalf of the COVID-bereaved Families for Justice United Kingdom. Represents many bereaved families across the United Kingdom. And for the purposes of the questions I'm going to ask you, it's important to record that some of them are bereaved of healthcare workers, and some of them themselves were healthcare workers during the pandemic, including on COVID wards. Now, on the 9th of January, you attended, so very, very early in the story, you attended a PHE strategic response group where it was agreed that COVID would be treated as a high consequence infectious disease, HCID, although I think it was formally classified as such a few days later. Is that right?
Yeah.
And
I think it's right.
Yeah. Okay. Well, I have the document. I'm happy to put it up, but I'm trying to work at pace. The minute of that meeting, I'll give the reference for the record. It's 119453. And the minute records that it was recognised that COVID, like SARS, was a virus with, quote, higher airborne transmissibility. And that would mean, wouldn't it, that it was recognised that it was transmitted either by aerosol or droplet transmission. Is that right?
So higher airborne transmissibility does mean that it could be transmitted via the airborne route, which includes large droplets and also includes fine particles, also referred to as aerosols.
Thank you.
But aerosol or airborne transmission is not part of the definition of a high consequence infectious disease.
Thank you for that clarification. I wasn't, in fact, suggesting it was.
No,
but that's what was recorded in the discussion, during which it was agreed between you and the PHE group that it would be, in fact, classified as a high consequence infectious.
And the reason for that classification at that point was that primarily, I think at that point we really did not understand with any certainty the infection or case fatality rate. We didn't know how lethal this virus was. And the HCID classification is used for things which you know are very lethal and used for things where you have uncertainty as to the lethality.
Yes.
It's the way you kind of start with a new organism.
Indeed. And in fact, the document goes on to say that it was agreed to follow a, quote, safety first principle, which is, I think, what you've just helpfully explained to us. In fact, the discussion and the classification at that stage was then added to by guidance. And again, I'll read it rather than put it on screen if I may, but I can if you want me to. It's 184034, and for the record, it's paragraph 4.3. And the guidance on the 15th of January that was issued with respect to this.
Could I have that up?
Yes, of course.
That's all right.
Yeah. Could we have that up then, please? I'll repeat the. It's 184034. Right. Sorry, can we just have the first page up first, just so we can orientate us as to what it is? Thank you. So it's the Wuhan novel coronavirus infection prevention and control guidance, 15th of January.
Yes.
So can we go to the paragraph that you helpfully had already been put up? Thank you. 4.3. Page before, I think, yeah, 4.3. So what was required was, firstly, an isolation room with negative pressure relative to the surrounding areas, or a neutral pressure single room. And then a use specifically set out, use of an FFP3 respirator by all persons entering the room. And then, I won't go through it, but you can see it there. Full PPE. Yeah.
Yep.
So that's what was.
And this is guidance issued by Public Health England.
Yeah.
Yes.
But this is sensible precautions for this type of virus, isn't it?
It's sensible and pretty standard precautions for HCIDs at this point in time.
Okay. So then move to the 21st of January, and again, I think we should have this up. It's 151342. And this is an email exchange between yourself and a PHE official. It's been redacted, so I don't know who it is, but it doesn't matter. But it's an email exchange. And the person confirms that there's no agreed requirement to stop calling it a disease an HCID in order for confirmed cases to be managed outside of HCID centres. Management in specific HCID treatment centres is deliberately not part of the agreed definition for criteria for HCID. We do have a line in guidance saying confirmed cases should be transferred to HCID treatment centres, but that could easily be changed when an agreed surge trigger is met. And then this. Personally, I would want to maintain the HCID label if it became more widespread, to maintain appropriate IPC, infection prevention control precautions, and general levels of clinical concern awareness around the new disease, as long as we still think it meets the stated criteria. Yeah. So what that means in summary is that you're agreeing with the PHE official that once the spread of the virus reaches a particular point, it's not required that they should be that patients should be within an HCID centre. Now,
not quite true. I think what I was flagging, that the HCID process, if you like, and the use of those very high security beds, there was a step down, and a known step down, to the 500 or so infectious disease beds, which again have enhanced infection control, but that there was no provision or understanding about what happened when you got to the end of those 500 beds.
Okay.
And it was very clear that we were going to get to there quite quickly.
Okay, well, can I take this in stages?
Yeah.
So the HCID scheme, if I can put it that way, is that there's a standing capacity of high isolation beds.
Yes.
So if there's a need for isolation, the HCID patient is put in there. But it's well recognised that if there's more than a small number of such patients, then that can't
It just
apply.
can't function.
And so it's
no.
completely impracticable to have a standing capacity of thousands of empty beds.
Indeed.
So it starts off with an HCID unit, small number of beds, and then if that isn't sufficient, you then have to open it up,
Yes.
and you move on to the high dependency unit capacity or whatever you have, and you have to use practical means to expand the capacity to the best isolation that you can manage within the capacity that you have. Is that right?
Yeah, that seems okay.
Yeah, okay. But what is being said here is that although that is fine, what should be maintained are the IPC precautions around that.
Yeah. So that was personally my view.
Yeah.
The other factor that was later, I was later made aware of, that is that specimen handling and the whole process of treating patients under kind of HCID rules means that your total capacity is lower and your speed of movement and handling of specimens particularly is lower and more cumbersome. And the classification of HCIDs lies with the Advisory Committee for Dangerous Pathogens.
I'm coming to that.
Good.
So the point is that it's recognised that you have to be flexible about capacity, and therefore the HCID classification allows for a surge, a trigger, which opens up the capacity, and you have to do the best you can with the capacity.
So I don't think it allows for it in the sense of it has always allowed for it.
Yeah.
I think this was new thinking.
Okay.
I think this was a new situation.
The guidance we've just been to sets out the need for the isolation units, but not in terms of specifically HCID units. But it does specifically refer to the FFP3s and the particular requirements of personal protection for the staff. And that's the distinction I'm drawing. So that's whether it's the HCID guidance or not, that's the guidance that was in place here, which I've just taken you to.
Okay.
Yes?
I'm all right so far.
Yeah. So by the beginning of March, as we heard from Professor Whitty this morning, there was then a question right at the beginning of March about the biosafety requirements of dealing with samples in labs.
Yep.
So perfectly sensibly, the CMO, the Office of the CMO, then consulted with PHE and the HSE and got the biosafety requirements stepped down so that the testing could be maintained, or the analysis of the testing. Yes?
I think so, yeah.
Yeah. And then we moved to the 3rd of March. And again, I'm trying to go at some speed here, so please stay with me. But then a DHSC official messaged that the standing capacity for airborne HCIDs had been exceeded, and therefore there was this outward movement from the very high isolation capacity outwards. Now that, you probably won't remember the date, but that was the 3rd of March. I can take you to the document, but I don't think it's necessary. But were you aware at this sort of time, the beginning of March, of that happening? In accordance with what we've just been through in January.
I can't remember the date, but I entirely expected that we could not continue to manage a very fast-growing epidemic of hospitalised patients on the infectious diseases network, within the infectious diseases network.
But this was what we've just been through, the 21st of January email. The expectation was that if this did become widespread, that this would be necessary. And here we are at the beginning of March. It has been necessary. The plan, such as it was, it wasn't unexpected.
No, I think I kind of flagged that,
Yeah.
that there was probably a gap in the plans that didn't kind of bridge between what we classically envisaged HCIDs to be handling,
Yeah.
such as Ebola cases, to something that was then becoming a
Okay.
persistent, and widespread infection. But let me just add a little bit to that, where the threat of infection to others was changing over time, so it was not exclusively about the healthcare environment, and it was starting to be more about the general community environment. In other words, the opportunities for exposure to the virus were starting to change. Whereas, if you have, you can have the infectious diseases unit, the HCID, full of Ebola cases, but there's no risk in the wider
Yes.
community.
Okay.
It's contained. This was very materially different.
Yes. Okay. So I'm now moving on to the final part of where I'm headed with this, and that's the 13th of March, and NervTag met, and I think we need this up. It's 212195.
Oh, thank you.
And that's the 13th of March. And if we could, and this is a meeting where the HCID classification is considered. And just to remind ourselves, this is where we're in the crisis phase, the exponential rise in COVID cases, okay? So if we could move to page 4, please, and paragraph 2.5. And this refers to, this is relevant to you, Action JVT. And then JVT noted that guidance was needed to help relieve pressure points on the NHS in England. And then there's the example of ambulances. Yes?
Yes.
And then if we move on to 2.9, please. The new guidance that's been proposed is then stepping down from FFP3 proper respirators to the kind of blue surgical masks that many of us are familiar with,
Yes.
having gone through it. So a real step down in PPE for people who are dealing with COVID patients at that point, at the crisis stage. And then, if I may, 2.10, there's a recommendation there that the reclassification of COVID from a HCID is considered by the advisory committee, which you were referring to earlier. And then finally, on this document 211, please, there's an update where you'd spoken to Professor Evans, who had advised that HCID status was discussed, and the committee were unanimous in supporting the declassification of HCID. Now, just to complete the picture, well, first of all, you've therefore got the recommendation that it's reconsidered, and then you've got effectively a decision in the next paragraph referred to, which suggests that the decision has already been taken. Can you help us with that?
No, I don't think that's the case at all.
Have I misread that?
Well, I mean, clearly they're sequential minutes, but the minutes aren't written the moment a NervTag meeting is finished. I don't suppose we have the publication date on these minutes, do we?
I'm not aware of that.
No, we just don't.
Okay.
But that will be worth looking into.
Yes.
But likely, having received an instruction from one independent advisory body in the shape of NervTag, who were requesting that ACDP looked at this, likely I moved very fast on that.
Yes.
And likely this should have been reported as an action point that I had done really quickly. And this was almost a kind of post-meeting note that was the consequence.
Okay.
I just can't spread any further light on that.
No.
But I refute the suggestion that this was a fait accompli.
Yes.
I'm extremely fastidious about appropriate procedure, and if NervTag had asked for that, I would have asked ACDP
Yes.
in due course.
Yeah.
This would not be kind of retro-constructed,
Okay.
as you might have been suggesting.
Right. Well, I'm exploring rather than suggesting, but
Yes.
the one paragraph says
It does.
A recommendation, effectively, and
Yeah,
the next one refers
says,
to what's effectively a decision.
Yeah.
And the reason that you, however it lands, the reason that you were in touch with the professor about this is because they were effectively the decision-making body.
ACDP, absolutely,
Yeah,
yes.
yeah.
And it would be worth possibly seeking some supplementary evidence from the ACDP minutes to understand exactly how that happened.
It may not matter, but I was then just going to take one final document, which is 119498, which is the 16th of March document at the top, although it does say the 19th of March at the bottom. It probably doesn't matter, but just to orientate us in terms of the date. But this is the Four Nations HCID definition and list group, chaired by the head of emerging infections. And I won't take you through it, but this is ostensibly a review of the HCID position and then changes the position at the end of the document. And of importance here is that this is a Four Nations group. So this is where the Four Nations are brought together. So in terms of this, first, I've got 2 points on this just to finish with, but who's actually making the decision here? Is it the professor from the group that you were in touch with on the 13th, or is it the Four Nations group? Were the Four Nations CMOs involved in this? I mean, what was the process here?
I am pretty certain, but I can't answer the question about whether the HCID definitions group was a subgroup of ACDP, but clearly my instruction was to contact ACDP. Yes. And it may well be that this is some kind of subgroup of ACDP, yeah. But the participants are from the public health agencies, yeah. Public Health England, Health Protection Scotland, Public Health Wales, and Public Health Agency of Northern Ireland, and therefore CORA. And I can't tell you who they were.
But the 2 dates, the 13th and the 16th, it does seem by the time this review has taken place, the decision's already been taken.
Look, I can't give you. I just can't give you any clarity on that. If I could, I would.
Final point. The upshot of this is that right at the crisis point, the classification of COVID is being downplayed. And one of the key points, perhaps the key point here, is that healthcare workers, there's now no requirement for them to have respirators. The requirement is for them to have simple surgical masks. Why is it that that happens in the eye of the storm, when the cases are going exponentially and healthcare workers are at the highest risk? Why is that happening now?
There wasn't the clearest understanding at that stage that there was that fine droplet transmission was dominant, and I can only surmise that the people who wrote the guidance, Public Health England, felt that the predominant route of infections was droplet, and therefore a surgical face mask was adequate. But I can't give you a better answer than that.
Well, I mean, you were involved in these discussions, but let me just put this to you. Was this decision to reduce the protection for healthcare workers because there simply weren't enough FFP3 respirators?
Not by me.
Thank you.
Mr. Wetherby, I appreciate you've been trying to stick to your time, and I'm very grateful. Did you want to ask the question about why did it take so long for medical masks to be recommended?
I wasn't going to go there, but thank you.
Thank you. Right, I think it's now 7.
afternoon, Professor.
Afternoon.
I represent the COVID-19 bereaved Families for Justice Cymru, and I just have 5 minutes, so I'll take it quickly if I may. Just one topic from myself, and that is in relation to the 4 meetings convened by Mr Gove in his capacity as Chancellor of the Duchy of Lancaster, and your perspective on how useful they were to a 4 nations approach to handling the pandemic. We understand from your witness statement that you attended some of these meetings. So if I can take it in a staged approach, please.
Yeah, okay.
We understand they started around May 2020. That's the evidence we have.
I'll have to go with that.
Okay.
I can't tell you.
And in terms of the purpose of these meetings, you say in your witness statement, ma'am, this is paragraph 5.12, that they were chaired by Mr Gove, and the purpose was to exchange information and to coordinate across the devolved administrations. So it would seem from that explanation that you're not suggesting to this inquiry that Mr Gove was using these meetings to gather views from the devolved administrations to inform UK government decision making. That was not the purpose. Is that correct?
No, not really. It was a much kind of, it was a softer exchange of views. I think really mainly by the ministers who were on that call about kind of what was happening and literally exchange of views and information. And I was there in the room really in case there was a technical question.
I'll come on in a minute to some specific examples of what may and may not have been said and jog your memory if I may.
Okay, yeah, of course.
Just on purpose, before we move on to that, was it also your understanding at the time that another purpose of Mr Gove's meetings was essentially to insulate the Prime Minister, the then Prime Minister Mr Johnson, from having to deal with the devolved administrations because, as we know, he thought it was optically wrong for him to have regular meetings with them? Was that your understanding at the time?
Oh, I have no idea. I can't answer that question at all. I didn't enter the meetings with that kind of degree of allegiance to.
Well, was that ever discussed in your presence?
CDL.
Was that ever discussed in your presence?
No.
This is the purpose of the meeting.
Absolutely not. No.
So on usefulness, you say in your witness statement that you did witness effective communication between core decision makers and the devolved administrations, and you cite an example of the meetings with Mr Gove. And I think that there probably isn't any dispute between the First Minister of Wales, in particular Mr Drakeford, and I think it's fair to say Nicola Sturgeon. They both acknowledge to this inquiry that the meetings were helpful and constructive. However, I do want to just probe your memory on a few criticisms that, in particular, Mr Drakeford has ventilated to the inquiry about the effectiveness and indeed the overall usefulness of these meetings. And really it's to understand whether you heard any of these complaints being raised in this forum. But can I check first, do you remember now being in meetings with Mr Gove and Mr Drakeford?
I definitely recall Miss Sturgeon being present. I'm pretty sure Mr Drakeford was present too at some points, but it's just a blur to me.
It's just a blur. But just thinking about how many you attended, I think you say in your statement that largely it was you that attended.
Yes, it was.
Okay. So these are some of the concerns or complaints that Mr Drakeford has given to the inquiry, and I want to ask you if each one or any of them,
If any of them,
you heard him saying that, or indeed any member of the DA saying that. So the first one is this. There was a lack, or the meetings were ad hoc, and there was a lack of formal structure to when they happened. Did you hear that complaint?
No, and somewhere in my dim and distant memory, I recall these were Wednesdays at either 5 p.m. or 6 p.m. They weren't a terribly sociable time, in terms of family life. And I do, somewhere I think I'm recalling that they were Wednesdays.
Okay. Next one, please. That there was a concern, and it might be fair to say that this was held quite strongly by Mr Drakeford, that these meetings, whilst helpful, were no substitute for high-level ministerial meetings. Did you hear that complaint?
Nothing heard.
And this is a very important one because it might be suggested that this goes to the issue of whether or not there was a coherent Four Nations approach. And this is that the clarity of messaging was a challenge for all Four Nations, and that more unanimity would be helpful, and that could only happen if the UK government gave more notice of its decisions and announcements to the devolved governments. Now that features regularly in written communication, certainly between the DAs and Mr Gove. Did you hear that complaint?
I did not hear that. As a slightly broader sentiment, I think I heard that there was some frustration about the timing of communication. Equally, I do recall on a couple of occasions that Scotland went first on a couple of points.
But certainly I think what you're suggesting is some of the concern was coming from the devolved administrations, that the UK government was perhaps making decisions and briefing the press without telling them first.
It doesn't sound like a totally strange concept, but I don't recall it from those meetings. I really don't.
And so finally then, did you hear any complaint from any member of the devolved administrations, including Wales, at these meetings about communications?
You know, I was there in a technical capacity, and the answer is I can't recall, but I don't think so.
Okay, thank you very much. Those are my questions.
Thank you, Ms Heaven. Mr Jacob, last again. Don't worry, Professor. Mr Jacob's used to people having turned their back on him. He doesn't take offence, but you have to keep your voice to the microphone. That's why I'm afraid he's used to it. We're not being rude.
Professor, I can be, I think, very short as it happens. My questions are on the same topic as the questions I directed to you, your colleague, Professor Whitty, this morning, namely financial support for self-isolation.
Yeah.
Could I actually just start with this? Do you agree with Professor Whitty's evidence of earlier today as to the importance of financial support for self-isolation?
I think it was, you know, very easy, or relatively easy, for people in well-paid jobs with very good employers who would allow them to self-isolate and who could continue to do their work in a kind of isolated way in the home. But I think it was enormously difficult for people who were not fortunate enough in our society to have those kind of jobs, who had jobs where it was, you know, kind of essential to earn money to actually be out of the house. And I think this was an essential part of the package.
Professor, my lady, if you don't mind me going a very tiny bit off script, I will be very short. Professor Whitty referred to heated debate within government on the issue. Is that something that you were party, or is that really his preserve, given his particular involvement in meetings in Downing Street and so on?
The package of support handed down to people who had to self-isolate, who were, for example, self-employed, was just kind of way above my pay grade.
Fine. Can I just ask this then? Was this issue on the importance of financial support something that was foreseeable prior to the onset of the pandemic? And I have in mind your own sort of research and expertise. Prior.
I think in influenza pandemic planning, and if you go back to influenza pandemic exercises undertaken by the government, the concept of school closures was pretty well rehearsed, to the extent that anything is ever rehearsed through a short exercise. But I think the kind of society-wide kind of lockdown and social distancing measures, particularly ones that were then applied multiple times during the pandemic in total to kind of put the brakes on each time, I think that was just way beyond anything that had ever been planned, and therefore and most of those exercises were about kind of technical issues related to antivirals, vaccines, health service responses. I'm not aware of any response on any rehearsal or concept of economic support being aired widely before this.
Yeah, that's helpful to understand. I had in mind something slightly narrower.
Oh, I'm sorry.
You refer in your statement to a 2017 article that you, I think, co-authored about influenza, I think in that specific context in care homes.
Yes.
And you referred in that article, didn't you, to care home workers being a group that, given their low pay and insecure work, were at high risk of working while sick.
Yes.
So in that sense, is it right that the link between insecure work, prevalence of working while sick, was something that was understood really from the outset of the pandemic?
I think it was quite narrowly understood in the context of care home workers and in the context of that being a very historically low pay sector. And in particular, there's a point there you didn't mention about the care home worker who works in 2 or 3 different care homes because they can get a shift here, a shift there. And together, by going to 3 different homes in a week, that makes up the family income. And of course, that's, kind of epidemiologically not a good idea when there's a respiratory virus circulating widely across the community.
Thank you, Professor. And I think that may be an issue taken up with other witnesses as well. Thank you, my lady.
Thank you, Mr. Jacobs.
My lady, may I detain you just for one moment, which is that although he's not made a rule application, Mr. Freedman, King's Counsel, has asked very nicely whether or not, based upon something that Professor Sir Jonathan Van-Tam has said in his statement, we would refer back to that article and just elicit a single point, which may mean we needn't put it to Professor Jenny Harris next week. Professor, in that 2017 article, did you and your co-authors warn, in fact, of the potentially devastating consequences of explosive outbreaks in care homes in the context of runaway viral infection?
I guess we did, in as much that we looked at the literature and we understood the mortality rate that is possible when an infectious virus gets into a very vulnerable population who live essentially quite close quarters to each other. The literature was all about influenza rather than SARS-CoV-2, so there are differences there. But that these were vulnerable populations, extremely vulnerable populations, I think has been known for a very long while. And I personally have dealt over the years, and I can't quite give you the details, as a registrar in public health with a number of really difficult to control explosive outbreaks of influenza in care home settings, nursing or care home settings.
Thank you.
That concludes the evidence for today. Thank you very much indeed, Professor Van-Tam. I don't know if you heard what I said to Chris Whitty in Module 1, but in relation to the abuse and threats that you described earlier, I've come across that kind of extraordinarily awful behaviour in another context, and I know the impact it can have upon the recipients, the victims, and the victims' families, even if they don't receive threats, which by the sounds of it, yours may have done. It's just too awful to contemplate. I just want you to be reminded, you probably don't need reminding, but just in case you do, the vast majority of the population abhor such conduct, and we are enormously grateful to you and your colleagues for the way in which you served the public of this country, of the whole of the United Kingdom, in a time of national emergency. So please ignore the violent, criminal, idiot element and remember the rest of us are grateful. Thank you. Sorry, I'm losing my voice.
Milady, thank you.
9:30 tomorrow.